We like to we like to do that so we can make sure that if people have missed it, that they can go back and watch this information. So, okay. So we're going to go ahead and get started. Um, Hi, everybody, and we're so glad that y'all joined us tonight. I'm Cheryl Arno. I'm the Executive Director of the Down Syndrome Association of Atlanta. And this is part of a group of agencies that support individuals with Down syndrome. It includes Emory University and Dr. Amy Talboy, who is with us this evening at the Department of Human Genetics at Emory. And then we have the Adult Disability Medical Healthcare, which Tamara Persley is the executive director. And we have Howie Rosenberg, who is the executive director of Gigi's. And those are the agencies that are trying to work hard to bring y'all this information. So we've started these webinars, and just to give y'all a heads up, at the end, during the Q&A, I'm going to put up a poll. It's very quick, but we just sort of want to know who you are and where you're coming from and what you'd like to hear in the future. This is, to be in partnership with Emory. We are so lucky to have access to some pretty spectacular speakers, I believe. So Amy and Catherine are going to introduce themselves. And I also want to tell y'all that I'm going to put in the chat so you can watch it on YouTube, this presentation on YouTube. If you forget that, you can just go to our website. It'll take us about a day to get it up, but then you will have access anytime if you want to go back. And the last thing that I will add is that the presenters tonight have asked that you put the chats in or put the questions in the chat, and they would like to get through their presentation, and then they will come back and we will go through those questions. Does anybody have any questions to get started, or are y'all ready to go? Amy and Catherine, y'all
Okay.
ready?
Yep.
Yes.
Okay.
All
Well,
right.
we so appreciate y'all being here tonight, and there you go. It's all yours.
Okay. Thank you, Cheryl. My name is Dr. Amy Talboy, and I'm a neurodevelopmental pediatrician and the medical director of the Down Syndrome Clinic at Emory. My colleague, Dr. Catherine Trapani, formerly head of the Piedmont School of Atlanta, holds a doctorate from the University of Wisconsin-Madison and completed a postdoctoral fellowship in developmental pediatrics at the Kennedy Krieger Institute and Johns Hopkins University School of Medicine. She's a certified behavioral analyst and educator with over 50 years of experience working with children with special needs. And she has extensive expertise in IEP development. So together, Dr. Trapani and I will be speaking to you tonight on collaboration in IEP development for children with Down syndrome. Physicians, educators, and parents really have to work together to assure best outcomes for our children. So while the overall population of the United States doubled from 1950 to 1970, during that same period of time, the population of adults with Down syndrome increased sevenfold. In 1960, you may be surprised to learn that on average, persons with Down syndrome live to be about 10 years old. Current epidemiological evidence suggests that the average life expectancy of people with Down syndrome is now over 60 years old. So individuals with Down syndrome are living well into adulthood and even into old age. Each year, there are about 5,700 babies born in the United States that have Down syndrome. This means that Down syndrome occurs in about 1 in every 640 babies. Currently, there are about 220,000 people with Down syndrome in the United States, 120,000 of whom are adults. There are many factors that affect how long a person with Down syndrome lives. So, as we consider best strategies for supporting these individuals across the lifespan, it's imperative that we try to understand and consider the interplay of factors that contribute not only to health, but also ultimately to quality of life. Children with Down syndrome are living longer into the adult years, largely because families and healthcare providers in the United States have learned over time how to improve medical care for people living with Down syndrome. There are a large number of health conditions that are more common among people with Down syndrome, as most of you know, and some of the more common conditions I've listed here, such as cognitive and developmental delays, difficulties with speech and language, issues with vision and hearing, congenital heart defects, sleep apnea, autoimmune disorders, early onset Alzheimer's, just to name a few. So our current knowledge of best practices in medical care has resulted in our current evidence-based standards of medical care with published healthcare guidelines for both children and now also adults. And I thought I would put a couple of slides in here. This article is from the American Academy of Pediatrics. It offers age-specific guidance for clinicians whose young patients have Down syndrome, and I included the reference and link. I really feel that, every parent of a child with Down syndrome should keep a copy of these guidelines so that you can be informed of what our healthcare guidelines are. And there are similar guidelines, well, not similar, but different guidelines now published for adults. These evidence-based clinical guidelines provide recommendations to support primary care of adults with Down syndrome. And you can find, this is the article, but you can find these care guidelines published or at the Global Down Syndrome webpage, and you can download them. And it even comes in family-friendly format. So in addition to this variety of health conditions, communication challenges are also quite common among people with Down syndrome. Communication can be defined as the active transactional process of exchanging information, ideas, emotions, and meanings between individuals through shared symbols, signs, and behavior. We tend to think of verbal communication, nonverbal communication, visual communication, and written communication. Verbal communication involves spoken words, tone, volume to express ideas. Nonverbal communication involves body language, gestures, gaze, and facial expression. This is often a strength for people with Down syndrome, actually, while verbal communication is often a weakness. Visual communication utilizes signs and symbols, and written communication conveys messages through text. So communication, when I think about it with children, I think of expressive and receptive language. Receptive being understanding what others are trying to communicate to us, and expressive language means conveying meaning to others by whatever means we can. As I said, individuals with Down syndrome have stronger receptive language than expressive language, and speech and articulation are also challenges. Speech and language therapy usually starts early in the early years, as soon as we start to have words, and it continues for years. AAC devices, I wanted to mention, can be useful in helping to bridge the expressive receptive communication gaps, and they do not impede the progress of verbal communication. So accommodations for expressive communication challenges are really important considerations when we develop IEPs. So this graphic, adapted from the Down Syndrome Good Practices Guidelines for Inclusive Education, outlines strengths and challenges associated with the main aspects of the specific learning profile for people with Down syndrome, as well as the unique range of their sensory, physical, and cognitive needs. So I know this is a really busy slide, but let me just walk us through some of the important points here, because it's important to understand this learning profile when working with students who have Down syndrome. So let's just start with hearing impairment. Many adults with Down syndrome experience hearing loss. It can be either sensory neural or conductive or mixed. Children, even if they have baseline normal hearing, often have periods of middle ear fluid or frequent ear infections, resulting in conductive hearing loss for periods of time. They will have difficulty learning in noisy environments, processing spoken language, discriminating speech sounds, and learning phonics. Verbal memory weaknesses. Children with Down syndrome have difficulty learning from listening. They may have problems maintaining attention, retaining auditory instructions, memorizing verbal sequences. Auditory sequencing is very difficult for them, and learning new vocabulary and information. There are challenges in retaining and consolidating learning into long-term memory. They require more repetition and daily practice or use to achieve long-term memory. Delayed motor skills are often present. Early motor delays are linked to hypotonia, but motor coordination and motor planning may be longer-term challenges. This impacts all physical activities. We see delayed self-help skills and handwriting challenges, but such challenges improve with practice. So intervention is really important. They may have difficulty staying on tasks and multitasking. They may be easily distracted and tire easily because of some of their motor difficulties. Speech and language delay is, of course, very prevalent. We have already reviewed some of the language challenges. Their expressive weaknesses may lead to underestimation of their knowledge. There are often weaknesses in processing long sentences, learning from listening, understanding new or subject-specific vocabulary, word finding problems, and difficulty understanding instructions. For those that read, reading comprehension is usually a weakness. However, these individuals are able to learn and use signs and gestures. They may learn to read and use written words. They have strengths in learning through imitation, from modeling, and from demonstration. They learn best from visual resources, concrete materials, and digital technologies and apps. And finally, visual impairment. Visual impairment is common in adults with Down syndrome. Many develop problems with visual acuity during childhood. They may have difficulty with depth perception. Many require glasses, some even bifocals. This has implications for writing, using a pencil on blue-lined paper, need for larger fonts, and higher contrast. So overall, people with Down syndrome are visual and kinesthetic or tactile learners. They desire and have the ability to learn from others, imitate and take cues from their peers. They have strengths in social understanding and relating to others, and we really want to build upon these strengths while addressing the weaknesses. In addition to a unique learning profile that I've just hopefully presented, individuals with Down syndrome also have certain behaviors that may occur more frequently under various circumstances or conditions. This is a listing of some common behaviors: short attention span, impulsive behaviors, slower thought processing. This means delayed responses, increased self-talk, delayed pain perception. Individuals with Down syndrome may experience not only delayed pain perception, but difficulty localizing pain and limited verbal expression, underscoring the importance of recognizing nonverbal indicators of pain. Agitation, pacing, restlessness, self-stim behaviors, self-injurious behaviors, disengagement from activities or shutting down, non-compliance, plopping, eloping, irritability and aggression. So these are behaviors that can escalate under certain conditions, like anxiety or stress, frustration, when they're tired, when they're sick, when they're in pain. So behavior is a symptom, often with underlying meaning or function. When behavior becomes problematic in educational settings, it will be important to look for associated contingents that perhaps consider the need for a functional behavioral analysis, which we're going to mention later in the talk. Understanding behavior is really, really crucial for creating inclusive and supportive environments for individuals with Down syndrome. By gaining deeper insight into why behavior occurs, we can provide strategies and supports that promote cooperation and learning. Social emotional factors also impact a student's performance at school. So, for example, the child with Down syndrome may have difficulty interpreting social cues. Anxiety and depression are also possible co-occurring conditions that hinder engagement. And problems forming friendships may lead to reduced social interaction or isolation. When these issues are present, interventions are needed and should be implemented. As we develop and implement individual intervention plans, we must bear in mind that our ultimate goal is to help the individual ultimately to attain good quality of life. Sherlock and Vertigo uh, um, developed a conceptual model on quality of life, and which has been widely accepted, critically evaluated, validated in different cultures, and used to assess the quality of life of people with intellectual and developmental disabilities. This model describes 8 dynamic, ever-changing, intertwined, and overlapping domains that contribute to quality of life. And those I have listed here include personal development, which involves education or personal competence. Self-determination, we want people to have as much autonomy as possible to be able to make their own choices. Interpersonal relations, social inclusion, rights, both human and legal, emotional well-being, physical well-being, and material well-being. I wanted to mention these because as we develop individual intervention plans and set a course of smaller step goals, I think it's really important to keep the big picture in mind and to keep these concepts in mind, to remember what we're working for, what we want to maximize. So individuals with Down syndrome, as I hopefully have presented here, have complex medical, cognitive, learning, social, emotional, and behavioral characteristics that contribute to their unique intervention needs. An effective intervention team for an individual child will require collaboration between multiple domains, between medical doctors, sometimes social workers, special educators, therapists, speech therapists, language therapists, occupational therapists, physical therapists, clinical and behavioral psychologists, behavioral analysts, parents, anyone who has a role in the child's care. For good quality of life outcomes, the intervention team really must ensure a holistic understanding of the complex child's needs. And this requires collaboration between a variety of providers. Clearly articulated and defined responsibilities have to be put in place within the IEP to assure accountability. So before leaving an IEP meeting, for example, the responsibilities of each person involved must be clearly assigned and documented in writing. When this happens, the IEP is likely to be of higher quality and much more effective. So it's important to understand that an IEP is an ongoing document that that complies with the law and that all of the providers are committed to. Responsibilities are shared among providers and clearly articulated. An objective method of monitoring effectiveness of interventions needs to be included, along with a time frame stated for review of the child's progress. If there's inadequate progress, the plan should be reconsidered and amended as needed. Successful collaboration requires clear communication to ensure all team members understand the goals and expectations, trust and mutual respect, which is sometimes hard, but does foster a positive environment where ideas can be freely exchanged. And additionally, setting defined goals and responsibilities helps prevent confusion and enhances productivity within collaborative projects. Accountable teams hold regular meetings and updates among team members. IEP meetings are required once a year or when called, but it would be better really if the committee agreed to check in on progress more often, say once a quarter, every 3 or 4 months. For accountable teams also use clear jargon-free language. That IEP should be written in a way that we can all understand. And members at IEP meetings need to be active listeners and show mutual respect. So I just want to mention the Individuals with Disability Education Act, or IDEA. IDEA is the primary federal law governing governing special education in the United States. So while passed in 1975, the latest major reauthorization of the statute is the Individuals with Disabilities Education Improvement Act of 2004. The purpose of IDEA is to prepare children with disabilities for education, employment, and ultimately independent living as much as possible. IDEA is built upon 6 foundational principles that guarantee specific rights and protection for eligible children with disabilities. And those principles include free and appropriate public education delivered in the least restrictive environment, educating students with peers who are not disabled to the maximum extent appropriate. So take note, this does not necessarily mean inclusion. It also, one of the points is appropriate evaluation. Everybody is entitled to an evaluation. The individual education plan, which is tailored to the child's unique needs. Parent and students are encouraged and expected to participate. And there are procedural safeguards. Parents have legal rights to review records, participate in meetings, and request due process. Okay.
Hey, thank you, Dr. Talboy. I'm excited to talk about this portion, which will go more in depth into education plans. It's the bane of everyone's existence. They are contentious at times, they're complicated, and certainly I'm not going to be able to explain all of the details and nuances that I think that you should know. So I listed at the end of the presentation an excellent book written by an attorney for special ed parents, for special ed professionals, so that you really can understand the basis of the law, what the intent of the law was, and how the law is supposed to be implemented. I really would never go to an IEP meeting until you really sit down and look at what your rights are, and what the intention of this law, the spirit of the law, as well as the letter of the law, entails for your child. So first and foremost, the education plan is an individual education plan. So it should reflect the needs of your child. And those needs are translated through assessment. So having a good assessment of your child before an IEP is written is critical, because the assessment is a roadmap of what your child's strengths, interests, and abilities are, as well as the challenges that they face. And it's important that you know both, because you're going to use the strengths to influence the weaknesses. So the IEP is crucial for your child's unique educational, vocational, social, emotional profile. The IEP is a binding legal contract. So this is a serious business. IEP goals, again, based on assessments, goals should be set at 90%. Why? Because it's only when a child masters something at 90% that they can use that goal across settings. They use that skill across settings. It generalizes. If a child doesn't achieve mastery at 90%, it doesn't transfer. Many times you're going to say that your child does something in your home that they don't do at school, and vice versa. This is the important reason for kids to have mastery at a high level. That is going to be a difficult thing to fight for. You want to know, and for quality of life, you have to look at this immediately. What does your child like? What are they willing to work for? Make sure that those things are embedded in the IEP. Collaboration is key, and it should be interdisciplinary. When schools share, their activities, their readings, vocabulary that they're going to be doing. If they can do it a week in advance, then you, as a parent, can incorporate the things that your child is being exposed to at school into your daily life at home. And that will strengthen the aims and the work of the school. Reevaluations should be occurring every 3 years. I'm making a point of this because I've been to some IEP meetings lately where I can see that there's some drift away from this, but you have to have an assessment to have access to special ed services. But then every 3 years after your first IEP, your child is supposed to be reevaluated unless the parent and the county school agree in writing that it's unnecessary. You can find the date of your triennial meeting on the first page of your IEP meeting, and you should look at it and think about what it is that you want. IEPs need to be reviewed every year. Educators, and when I say educators, I mean all of the people at school involved in your child's education, the special ed teachers, the counselors, the school psychologists, the speech and language therapists, the OTPT, anybody who's working with your child can potentially be part of your IEP meeting. It's up to you who you wish to attend your IEP. When you ask for an assessment, whether it's an educational assessment, a behavioral assessment, a vocational assessment, you've got, again, timelines are different from county to county, but the Georgia Department of Education lists on their website exactly what the state requires, and typically it's 60 days from the receipt of your consent to have assessments done or to enter into special education services. Physicians are critical, especially with children who have medical complications, because they can inform the IEP team of the effects of hospitalizations or certain assessments that are done of a child medically, that the implications that those things may have on learning and behavior. Similarly, a physician can help explain the effects of medication on learning and behavior. And these things should be taken into consideration as you're forming IEP goals and developing plans for the future. Parents are essential key members because it's your observations and your knowledge of your child. No one knows your child the way that you do. And so you have to, unfortunately, everything is left to you as a responsibility. But your observations, your knowledge of your child's likes and dislikes and their needs is critical in helping to inform the school and the team of the motivations, what would motivate your child, what your child's interests are, and similarly, what your child doesn't like or what your child is afraid of. These things should be included in the IEP so that it enhances its effectiveness. Everyone together collaborates to set realistic goals. We want to keep going. New slide. Next slide. Okay, so the purpose of every IEP goal is to prepare your child, irrespective of how young or old they are, for the next transitional milestone. So to move them closer to the goal of having a successful transition from school to post-secondary settings and have quality of life. I cannot underscore the importance of starting as early as possible towards that end goal of what it is that you want for your child's future. Even if you have a child in early intervention, I encourage all parents to sit down and talk about what they envision for their child 5 years from now, 10 years from now, 20 years from now. Why? Because it takes a long time to achieve your goals and because time goes very quickly. And some of the planning that you need to do takes a great deal of time and involves not just individual people, but whole organizations. And so moving forward is critical. You want to enhance coordination of services. You want to know for sure who's doing what, when, and why. You want to customize each goal. Again, always to underscore strengths, interests, talents, curiosities, as well as use so that you can use those things to develop the things that challenge your child, the things that they inherently have difficulties with. You need to consistently monitor where your child is standing now, what goals are lagging behind, what skills are seriously in need of improvement in order to move them to the next level. May I have the next slide? Next slide, please. Okay. An effective IEP for a student with Down syndrome should prioritize the visual learning strengths while addressing the auditory processing and the memory and the motor skills deficits that Dr. Talboy talked about earlier. Very critical to also incorporate interest in socialization and curiosity about the world. We need to approach learning through the strengths of our kids. We need to embed goals within everyday activities that they're truly interested in: cooking, shopping, planning, going on an outing. If you do those things by way of embedded instruction, you're incorporating reading and measurement and telling time and using money and learning how to sequence things in small steps. Next slide, please. All right, so I changed things around here, but I'll just keep going with the flow. Individuals with Down syndrome are more at ease when they know what to expect. So shared routines and expectations, again, that are visually posted. First this, then that, then this. So they know what to expect. They can see what's happening and how the day is moving and how they're moving, helps them to navigate through the day and minimize some of the frustration that they experience. Next slide, please. All right, so elements that should be included in an IEP. Dr. Talboy talked about communication, talked about behavior. Academics should be practical. Adaptive life skills are critical, and post-secondary planning is essential. And again, start early. So even though your child might be in early intervention, I'd start looking at those skills that you could start teaching early so that you get to the place that you want to go. Communication is receptive, expressive, and pragmatic. Please make sure in an IEP that the school system includes pragmatic or the social aspect of language, because for our kids, that's going to be critical. Learning self-control, self-monitoring, and controlling aggressive tendencies or noncompliance and stubbornness is critical. Academics, again, only geared towards basic life skills. Adaptive life skills, I'll talk more about. Self-care and post-secondary planning, I'm going to talk a lot about transitions. Next slide, please. Okay, the Global Down Syndrome Foundation and the National Down Syndrome Society. And at the very end of the talk, I've given you slides that you can call these organizations, you can email them, you can join them, because they all publish incredible information. They state that IEP goals should be specific and measurable. So if we're looking at communication, expressive language, we want the kids to use multi-word phrases. Receptive language, follow multi-step directions, which will be critical for their future, with visual cues. Visual cues should be part of everything. Literacy and numeracy, sight word recognition, reading fluency, how fast someone could read something, functional math skills, counting, money management, telling time. These skills should be reviewed regularly, but I very much suggest that in your home, the child shouldn't feel like home should be a safe harbor. Play games that require counting money or solving multiple step instructions. Play Zingo, play bingo, play board games like allowance, do story sequencing blocks so that they can break things down into steps, but they have a good time and they're playing with you. So it's a social time rather than sitting down at a desk like they do in school. Fine and gross motor skills, keyboarding, handwriting, use of scissors, even if they're adaptive utensils, balance and coordination, all critical. But again, something you can do if you see what they're doing at school, translate it to home, but make it into a play activity. Social emotional skills, to start very early on, getting along, going along, initiating conversations, having friends over, set that up with your child and teach them how to be gracious with a friend and to share, because those are the skills that are going to open doors for your child in their adulthood. Next slide, please. Okay. There are teaching methods that have research documentation. So we want to differentiate instruction, which means that you are going to have tailored teaching methods that suit your child's needs. In terms of content and assessment, and everything's going to should be adapted to your child's cognitive profile, their language, their comprehension, both in the strengths as well as the weaknesses. You want to really focus on visual vocabulary, teaching vocabulary words every week, not memorizing them, but showing them a picture, an action, modeling it. Take a picture of them doing that word or engaging in that activity, and have modeling and repetition over and over and over again so that they build that vocabulary that's needed and then build those phrases that are needed. Kids need to get regular feedback, informal assessments, little quizzes, pop quizzes, little tests. To make a big fuss about something that they remembered or something they knew and did well moves them forward. It's something to share with the family. You can do that at home as well. You can share with the teacher what your child's doing with you and how they're doing. Learning accommodations. I'm a big fan of time to learn. In other words, sometimes it takes some children 1,000 teaching trials, but they will learn something. And when they do learn it, they will remember it. But you can't give up. And the idea of repetition and guided practice across settings with different materials, teaching the same thing, will assist your child in accomplishing what needs to be accomplished. Next slide. Okay, so some of the accommodations that your IEP team could be making is the use of visual schedules. So now again, it needs to be big. I was in a classroom a few weeks ago where the visual schedule was just all typed and it was on an 8.5 by 11 piece of paper. This needs to be a big piece of paper, a display board. The font should be at least 18 points big, and it should be colorful, typically broken in half. And you can do this at home for your child too. What's the schedule for the day? What are the expectations? Are they going somewhere? Do they have therapy? Do they have chores? As a child finishes the activity, you take it down and you put it in a finish bin to help them know that their day is moving, they're not frustrated. Again, the concept of time is difficult in the beginning. So visual schedules, social stories, cue cards, anything to help supplement the words that you're talking. Pace and give extra time when things get hard. Take a break if your kid gets frustrated. Maintain predictable classroom routines. All of this should be in the IEP, reflecting what your child's frustration level is. The child needs to be in the front, they're in the front. If they need to be next to the teacher, they're next to the teacher. Physical adjustments like that, pencil grippers, sloped writing boards, anything that's going to help your kid learn. Speech to text apps, tablets, software that speaks back to you, lights up, reinforces the kid automatically are all critical. Brain breaks are critical. When children get antsy, when they get frustrated, they need to take a break, and there's nothing wrong with that. Next slide, please. Next slide, please.
Right, there you go.
All right. All right. Behavior intervention plans should be assessed. Behavior should be assessed when a child's behavior threatens their ability to benefit from instruction and/or they become unsafe to themselves or others. These intervention plans should lead to the intervention is preceded by a functional behavior assessment. Best practices in Georgia is that the functional behavior assessment be completed within 30 days, and within 60 days, a plan is already reviewed and implemented with data and consistent reviews of the data. If your child needs a behavior plan, get one. It doesn't mean that they're always going to have one. It protects them. It protects them from, it keeps them safe, but it also protects them from being expelled from school or for them not being understood. Next slide, please. All right. Adaptive life skills are essential, and you should start teaching them from the very, very beginning. Most groups put them in three categories: conceptual, money and time, social, communicational, interpersonal skills, and practical self-care and home management. I would pay huge attention to things like taking care of your belongings, packing up your bag, brushing your teeth, washing your hair, taking care of yourself, picking up your clothes, getting yourself through the day. I would set a kid up with chores immediately, with an allowance immediately, with all sorts of bells and whistles in terms of reinforcement for doing the things that you need them to do. Treat them just like any other family member and expect that they have a responsibility towards your family. Ultimately, the skills that come from doing that are going to be reflected when your child has a vocational assessment and you need to start doing formal post-secondary planning. Next slide, please. I'm going really fast because I want to save time for your questions. All right, so key elements for transition planning. You want your child to understand who they are and what their needs are. You want very much for them to be able to say that they have pain, or that someone hurt their feelings, or that they're angry. And so that takes a long time to help a child acquire and express those skills. We need real world academics. As I said before, a child, again, when they get to be 14 or 16, that's when formal transition planning happens, and you want job shadowing and internships and exposure to work so that your child knows what they like, what they don't like, what their interests are. I suggest that you begin early, take your child out in the community as much as possible, and pay attention to what makes them calm, what makes them happy, the place they want you to take them to again. Daily living skills, hygiene is essential. Cooking and food hygiene is essential. How to use public transportation safely, how to have stranger danger, how to say no, how to set boundaries so that your child is safe in the community. Health transitions are critical from childhood to adulthood. You're having to shift your whole set of healthcare providers. It comes under a different payment strategy. So you want to be able to teach your child how to take their medicine if they take medicine, why they take medicine, what it looks like, and for them to follow a schedule and take it themselves. Transfer of rights. Before your child reaches 18, you need to think about whether they are going to be competent or whether you're going to have to establish guardianship. That takes a long time. It involves attorneys and assessments. And so start thinking about that when your child's 15 so that you're not scrambling at the last minute. Next slide, please. Okay, I'll quickly. Current events. Congress is the one that passed the whole IDEA. In the beginning was the All Handicapped Children's Act. The Congress established the department, the Federal Department of Education. Only Congress can dismantle the Federal Department of Education, although the Federal Department of Education has been cut in half in terms of personnel. Critical because we no longer have the oversight in terms of making sure that counties and states within the federal government are complying with the letter of the law. But as it is, the IDEA exists. Nothing has been taken away. Next slide, please. The same thing with 504. Here are some of the impacts very quickly. If the DOE at the federal level is dismantled, basically everything will shift from federal oversight to state oversight. We won't any longer have a federal dedicated allotment of funds. That will be shifted to block grants to the state. That will cut down on services ultimately and disparity in the provision of services. And so that's something to be mindful of and to pay attention to in terms of current events. For that reason, I encourage families of any child with special needs, irrespective of their diagnosis, whether they have autism or learning disabilities, attention deficit disorders, Down syndrome, physical disabilities. Now is the time for parents of students across all diagnostic categories to form unified, collaborative partnerships with each other and with every association that deals with a child in need, and all service providers to advocate for the academic, social, and transition needs for their collective children in all public and private schools across the nation. God helps those who help themselves. And I think that with the potential to have oversight shifted, we really need to work together as a unified collaborative group so that these kids get what they need and they do have quality of life. Again, we left lots of citations at the end so that you can get in touch with organizations and get more information. And now we're happy to take questions. Thank you so much.
Hi, so thank you so much. That was a lot of information. We don't have any questions in the chat. Can you stop sharing, Amy? And then that way we can, there we go. Okay. It's so nice to see everybody. So if you want to put a question in the chat, you can raise your hand if y'all have any questions. There is going to be a lot of changes. We don't really know what those changes are going to be immediately. But maybe Catherine can speak to that. I do also just want to point out, and Helen did it right after I started, the Emory conference that we have coming up on April 18th is not to be missed. We do it, and when I say we, it's Emory and the Down Syndrome Association of Atlanta, Gigi's Playhouse, and Adult Disability Medical Healthcare, ADMH. We're bringing it to you. So that way, if you can't travel to Orlando, we're bringing it right to Atlanta. We've got great speakers, and I hope that y'all will attend. As I said earlier, the link is in our chat. So please make sure you sign up. Any questions that,
There was a question about ADLs. It
oh,
flashed
right
up
there,
and then
yes.
it went away.
No, it's right there. Thanks for, can the IEP include help with personal life skills, ADLs?
Yes, because that is a part of the need of every child with Down syndrome and most kids in every special ed population is daily living skills. And so, yes, that should be part of the IEP, even from early childhood. Washing hands, brushing teeth, personal hygiene, all of those things should be task analyzed, taught with opportunities throughout the day to use those skills. So absolutely that can be part of your IEP, and it's critical that you have it be part of your IEP.
She said that she's having trouble with her child's school with reinforcing these.
I don't understand. Reinforcing them, rewarding them, or
Jamil,
implement.
Jamila,
Yes.
you want to,
Hello.
there you go.
Yeah. So basically, those are things that we're teaching at home, but when she goes to school, it's not being reinforced. When I'm picking her up, her face is nasty. Just her panties are not clean because she can't wipe good, and I keep trying to explain to them that her motor skills aren't good. She's in OT, of course, and they know this, but just trying to get that extra help. And I don't know what to do about that part.
Is it in your
Because,
IEP? Is it in your
um,
IEP that they teach her how to wash her face and help wipe herself?
no, not exactly in those words. It's just, like working with fine motor and gross motor skills, helping with those things. So it's more of them helping with like the beating and trying to get her to use her pinchers, things like that. So
Okay. So the
yeah.
next time I think you should ask your IEP team to have a little meeting, and rather than put it under fine and gross motor, I would put it under adaptive life skills. And
Okay.
I would talk about the importance of taking her before lunch and after lunch or after snack time to wash her face, to wash her hands, to wash her face and hands before she comes home. She should be learning how to do that on a regular, timed basis anyway,
Yes.
in terms of hygiene. Now, some schools are good about teaching toileting, and other schools not so good because they all have different rules and regulations about what can and cannot be done in the laboratory. So I'll find out. But if she needs an aid for a period of time, just for toileting time, then ask for one so that she learns how to keep herself clean.
And
Okay.
it
Thank
has
you.
it has to be an IEP goal.
Yes, you have
Okay.
to put it in the
Concrete
IEP
goal.
Okay.
under the category of adaptive life
Adaptive
skills.
life
And
skills.
they have to
Okay.
document progress toward that goal, and you want a 90% success rate.
Okay. Thank you.
I also want to
Again,
add, if I can add anything, is as you
please.
look to the future, so things like for camp, a child has to have good activities of daily living to go to camp. Because we don't allow our staff at camp, and it's only a week, but we don't allow our staff at camp to take care of those needs. And if post-secondary is on anywhere on your radar, you're going to want to make sure that these are very active goals. And like Amy said, to make sure that they are getting 90% accuracy. Okay,
The
so
other reason why
Mhm.
it's important is for your child's safety. They need to be able to take care of their private, personal business on their own so that strangers aren't doing it and they're not at risk for being abused. So
Absolutely. Okay.
it's critical, and you need have every right to insist about it.
So we have another
Okay.
question. Thanks for it. I'm going to go to the next. Is that okay, Jamila?
Yes. Yes.
Okay.
Thank you.
So they wanted to ask if a reevaluation prior to the eligibility of 3 years, can you ask for that? And if so, what may be a reason?
You can get an early childhood assessment, I mean, with Down syndrome early on, and so that they get preschool services. No?
To get a reevaluation? Are you asking Amy?
I'm
But-
asking, did I understand the question? Can the child be evaluated before 3?
Before your 3 years, yes.
They should be able to, yes, because some of the language, the communication, and the motor training can start earlier than that. But Dr. Talboy, you can perhaps answer that question better than I.
So I think this speaks to the idea that typically when you enter kindergarten, well, when you enter special needs preschool at age 3, you get a full evaluation in order to develop your IEP and those goals. The next full evaluation occurs at age 6. That's 3 years later, typically when you're in kindergarten or going into first grade. You can correct me if I've got the timing right on that. But thereafter, every 3 years, you have a right to a reevaluation. That includes a educational evaluation. It's a psychoeducational evaluation, right, Kathy?
Yes, but why many public schools have early intervention programs and they start sooner than 3 years. Some of them start at 18 months. So you need to find out if your school
That's
district
the baby's gateway
offers those. No, I'm talking about the county school systems. So Gwinnett County has an early childhood program. Not all of them do, but you need to find out in your county if they do. If they have an early childhood program, then yes, you can get an assessment for that.
Okay, the question is, can you ask for a full psychoeducational evaluation in less than 3 years?
You can ask if they have an early intervention program, because they would have to
It's
evaluate
not before
them.
3 years. It's like, whoever asked this question, tell me if we're asking the right thing. So is it before 3 years that you're trying to ask for, or 3 years that you're trying to ask for, or is it as you get evaluated every 3 years? So who asked the question? Toya Barnes. Oh no, that's
I
not.
think, okay, so I'm reading the question. Would you suggest that I write out, wait, sorry.
No. Can you ask for
The eligibility
reevaluation?
evaluation for an IEP is every 3 years. Can you ask for an evaluation prior to 3 years?
Yes, you have to, in writing, request that you would like to have an area evaluated prior to the triennial evaluation. You have to say why, and that has to be considered by the team. You have every right to ask for it. Yes.
Can you
I
explain?
also,
Sorry.
I want to add one more thing to that is some school systems are now just doing 1 or 2 or 3 evaluations and they're getting pretty skimpy with those.
Yep, I know.
But also like for post-secondary education, if that is again one of your goals, post-secondary education, you have to have for Kennesaw State University, you have to have an evaluation within 2 years of graduation. And for the other colleges, it's 3.
Right.
So hold on to an evaluation if you can.
And even though it's true, and that's the reason why I went back to the structure of the IEP, there has been a lot of drift I've been noticing in the IEPs that I've attended recently that people aren't sticking to the letter of IDEA, but IDEA is still fully in place. It is still the federal law that governs education for children with special needs. And so you're entitled to everything that falls within the structure of that legislation. And so a triennial evaluation and anything that is needed before then can be considered. It is part of the governance.
Okay, so this goes into the next question. What happens if you accidentally, which makes me chuckle just a little, if you accidentally find out some services are not being provided that are outlined in the IEP? For example, OT services or speech, and the reason is staff shortage.
I would suggest, again, we're all always doing a fine dance between what you need and what's given and why it's not given, and you want to be collaborative and cooperative. But at the end of the day, we need to advocate for the needs of the child, and we need to make sure that everything that we do is contributing to the potential that they have quality of life. And so if there's a service that's listed in the IEP that isn't being delivered, I think it needs to be addressed. You should probably, I like to be collaborative with people, go to the director of special ed, sit down and talk. Now, I'll tell you, there's a national teacher shortage. There's a shortage of speech and language therapists and occupational therapists. There's a shortage of everyone. And so administrators are having a very hard time filling the roster of service providers in their schools. Nonetheless, your child still has needs. They agreed upon those needs in an IEP, and you need to have the service. So you need to talk it out and you need to find a solution. Even if they hire
Okay.
someone privately to deliver the services in the school day.
Emily, I'm going to get to you in 1 minute. So, newbie mom here, little guy is about to be 3 in June. When you say reeval every 3 years, isn't that something his current therapist, whether in school or not, should be doing? Explain LRE. And would you suggest that I write out his strengths, likes, what motivates him, etc., before his first IEP?
Oh, yeah, yes to that. Any observations and knowledge that you can share about who your child is and what they like is critically helpful. And LRE is the least restrictive environment. So you don't want a verbal child to be in a classroom with all nonverbal children, blah, blah, blah. You want them to be in the least restrictive environment based on their needs. And yes, there are two different kinds of assessments. There are formal standardized assessments like IQ tests and diagnostic educational tests that typically are IQ tests are only done every 3 years. You really shouldn't be doing them more often than that. Diagnostic educational testing is usually done once a year in a pre-post fashion. But then there are what we call criterion reference tests, which are informal assessments on the learning material that they're learning, and your child is just being assessed, and it's not normed or compared to other children at that age group. And yes, those are ongoing. And if you have a really good IEP team, you're going to find a way to make a plan with the teacher so that you get that information on a weekly basis, how your child is doing. At the end of the day, that's the most important information.
I just like to
Okay. And
I would
sorry, go ahead,
like to
Amy.
add that not only should you write out his strengths, likes, motivations before the first IEP, you should do that before every IEP. And
Yes.
you should do it with every new provider that comes into his life. If it's the teacher changes out, if there's a substitute, if you get a new therapist, that kind of information is critical to setting up ways of working with him that will be more effective. And anything that you can get in writing in the IEP that you think is pertinent to how to work with him should go in there.
And Emily, you've been waiting so patiently.
Hey, I just want to say thank y'all so much for the presentation. I'm a huge super fan, Dr. Talboy. I brought my daughter to you for like the first 4 years of her life, and we moved to the Savannah area. So I'm here to report she's 9 now. She's doing fabulous. Your insight is amazing. And just thank you both for presenting some very useful information. So I can speak to the triennial versus because this year I've had 7 IEP meetings. We're about to have our 8th. We found out my daughter has binocular vision dysfunction, which I thought I'm taking her to the optometrist every year. She wears glasses. Like, what else could there be, but she does have that depth perception challenge. And it is, interfering with her reading ability. She cannot tolerate visual clutter because she can't focus. The eyes don't work together, something that she can't communicate to me, so it's a lot like a guessing game sometimes, but she just had her triennial last year, and I did get full comprehensive evaluations again this year. It just has to be more than 1 year from the last evaluation, and the parent can request it in writing, like it's already been stated. And they have an obligation to evaluate children in all areas of suspected disability. So I would use that language because that's straight up from IDEA. It's Child Find 300.111. They are tasked with identifying, locating, and evaluating every student in the district with suspected disability, and a parent's suspicion is enough to trigger child find, and there will start a timeline. It's different everywhere. It has to be done within a reasonable time. But if they had their last triennial within a year or more than a year ago, a parent can request a re-eval, or you can, if it's been less than a year, you can disagree with their evaluation results, and the district has to pay for an IEE, which is a independent evaluation. So it's by a private provider that the district does have to pay for. So we do have all those protections in place. But my question is, as far as binocular vision dysfunction, I read that it affects 25 to 50% of people with Down syndrome. So I'm wondering, Dr. Talboy, if you have seen that, because I had never heard of it. It's a low incident disability. The school doesn't really know anything about it. But I had to fight so hard, y'all, to get that vision evaluation. It took 6 months. I hired an advocate. We got it. Anyway, I won't go on and on, but that's my first question about binocular vision dysfunction. And then also, she does take Synthroid, right, for hypothyroidism. And you inspired me to think, could that impact her learning hypothyroidism? And I would love to just get your reaction and response on that. So thank you very much. And again, I appreciate it. It's very isolating to be a lone parent in a meeting, even with your partner, full of educators, and have to take them on. It can be so intimidating. And I just appreciate the support, because as a parent, finding resources, especially affordable ones, are challenging. So your participation and presentation means a lot to me. Thank you so much.
What did your doctor say to do about the convergence problem? Because a child with that problem will have difficulty learning to read. So what was their outcome for therapy, for intervention? What'd they say?
So we are taking her to a private vision therapy once a week, which is another question I have, if that's been found to be productive. So we're doing that. We're patching her eye. They suggested enlarged print, a certain font. I mean, I called the Georgia School of the Blind. I got the Smokey Powell Center to do a field evaluation on her. That's free. There's all these resources. We just have to know where to find them. But I had to fight for that. Oh my gosh, I've had to fight so hard. But yeah, so, and they also said no visual clutter, like chunking assignments. But the school's not doing any of it. So we'll have a come to Jesus on May 6th. But, that's the other stressful
County
part.
is supposed to have either a consultant or a person on staff who does visual assessments and adaptive learning recommendations for kids with visual impairment. And she would come under that. So I would ask about that. Some districts are more sophisticated than others, but I think Chatham County should have a service for that.
We're in Bryan County. We do at Richmond Hill. We do have a certified vision teacher. She's not full time.
Okay.
She did evaluate her. So, but that's another added eligibility now, right? But they wanted to put her under OHI, and I'm like, well, there's no specialized instruction with that, and Down syndrome. I don't. Anyway, you know what I mean. So we got VI. Yeah. So it's a fight, but it's well worth it because she's going to get the services she needs. So I don't know. We do have a certified vision teacher to answer your question. She did do a vision evaluation.
Okay.
So I might add that number one, who diagnosed this? an ophthalmologist? An opt-
I'm assuming it's a functional exam, right? So, and it wasn't our regular optometrist. They don't even diagnose that. She had a screening for it, but we had to take her to a separate one. There's one in Savannah. It's 45 minutes away. They do vision therapy, which I'm taking her once a week for that now. But so that doctor did diagnose it. We're seeing a therapist for that's the protocol, I guess you will, is the vision therapy.
So I was going to say you must have somebody good to even diagnose it, because lots of ophthalmologists do not diagnose that. And not only that, even if you had a vision person in your school system, they might not know the best accommodations and how to handle this. So what I would say is I would take all of those recommendations about her vision and have your doctor write a letter of medical necessity for the accommodations that are required for her, and make it sound, it needs to be, you will, in my experience, it is very hard to get a doctor to write a letter, right?
Yeah.
So you might have to write that letter, put what you think ought to be in there, and tell them, look, I'm just trying to make life easier for you. You can amend it as you want, but we need a letter of medical necessity for these visual accommodations in the school. And with that letter of medical necessity in hand, you may be able to go to your IEP, submit that as part of your IEP, and make sure that every single one of those accommodations get put into the IEP in writing as something that is medically necessary.
And to have them put it into plain speak so the teachers
Yes.
can understand.
So it can't
They
be.
don't, and I printed out I did a whole research thing on BVD. I emailed it to the teacher. I said, share this with her PE teacher, her specials teacher, because they have no idea what it is. They're so
Well,
right.
good luck getting them to read it, but
I hate to do this, but we need to. I got more questions. I'm so sorry.
Sorry.
It's okay.
But just to say
I hope
one
you
more
got
thing,
answered what you needed to get
it's
answered.
more common than you would think.
It's wild, and it explains so much. I'm like, it's amazing. So thank you very much.
Okay, so the next question is Hannah is curious about Lavoxerine, whatever effect.
Leucovorin?
Thanks.
No.
Yeah.
Levothyroxine, is that what you?
Thank you.
Levothyroxine.
Yes.
Levothyroxine is thyroid hormone.
Oh, thank you. Thank you, Hannah. She just said it's not thyroid.
Is the question, what is it, or
about the effects.
The effect of that on
learning. It's not so much the effect of the medication. It's that low thyroid causes problems with low thyroid in infants, it causes brain damage, right? To begin with, this is why we screen every newborn born in a hospital in the United States for hypothyroidism. But as you get older, if you're low thyroid, it does make you gain weight. You're tired. You have no energy. You don't feel well. It's not
concentration.
Good. Concentration. Hyperthyroidism, too much thyroid hormone, can cause agitation, hyperactivity, sweating, all kinds of things. Low thyroid, you're kind of cold and don't have good temperature tolerance. But at any rate, either high thyroid or low thyroid hormone will cause you not to be well. So thyroid hormone, it's synthetic levothyroxine is thyroid hormone that we give to people who don't have enough. It's like giving insulin to a diabetic. That's sort of an analogy. So if your body doesn't make thyroid, you take the thyroid hormone. But it does have an impact if it's not right. If your thyroid levels are not right, it has a very significant impact on learning.
Thank you. And one last question. What is the law or requirement for communication of IEP goals progress with parents? I do not get a lot of communications back except when time to redo his IEP. So wondering how often they are supposed to communicate progress goals. And just also, just so y'all know, your poll should have just popped up. If y'all can make sure that you take just a minute to fill out those polls. So did y'all get that question?
Yes.
Okay.
It's
It's
not
an interesting
unusual.
question. I wonder about that
It is,
myself.
it's wonderful question. Usually most people just go in for their IEP meeting every year. They're in, they're out, and you don't speak to each other until the next IEP. That's the worst thing you can really do. I think you need to embed into the IEP a communication system in keeping with the slides that we gave in the presentation. It, think about what kind of communication you want. In other words, what do you want communication about? How do you want that communication delivered? A daily IEP, a weekly progress note, a home communication log that goes back from home to school. So you write in it and inform the teacher what's going on, and the teacher writes in it and informs you what's going on. Sit down and talk about what's possible and then write into your next IEP, or if you've already had it and you haven't done this, can always ask for another IEP meeting to make an amendment and have the communication written into the IEP about how often and what kind of information you want to be receiving. It's
And
critical.
and if your child is not progressing toward their goals, there needs to be changes in that IEP. Though obviously there's something is not okay.
Yeah, my rule of thumb is with people I'm working with, if you don't see progress in any given goal or set of goals in 3 months' time, you want to be asking questions why? What's going on? How is the instruction being delivered? How is your child doing with that? So that you can move things along. You have to take responsibility, unfortunately, to keep things moving forward.
And
So every 3 months is not unreasonable.
and if you don't know what individual goals are being worked on, you could have a goal that you're working on at the beginning of the year and you're still working on that goal at the end of the year. That's okay, but you want to make sure that some progress is being made toward that goal. And you won't know that unless you get feedback on a regular basis and know what they're working on.
I know the school makes you all feel terrible whenever you ask for anything. They don't mean to do that. Believe me, they're overwhelmed. But if you don't advocate and if you don't push, then it's going to take way longer to achieve the things that your child needs. And look at how complex it is to prepare your child for when they're 22 and the school is no longer responsible for them. So you'll make life better for your child and yourself if you keep pushing in a nice way to keep things moving forward. It is not unreasonable to ask for information.
There is a question about should an endocrinologist write a letter? I think any doctor that you have that has some special information about your child could write a letter if you wanted them to. But you might have to sort of do a template for them.
Maybe. Okay, if that's all, is that all the questions we have? Okay, I can't thank Amy and Catherine enough for tonight. This was, I know I learned a lot. And I'm going to say it one more time, make sure you fill out the poll and make sure you come and see us at the Emory conference. Amy will definitely be there. So
I'll be there too.
I'm just going to
and
say
Catherine
this.
will be there as well.
I just want to put in a couple of words for that conference. It is one of the better conferences that are these regional conferences. It is a super good conference with national speakers coming in, and some of our local speakers are better than some of the national speakers at national meetings. So it's a very excellent conference. You should come if you can. It's
And
on.
very supportive parent attendance.
It's
And I also want to say, if you feel like you can't afford it, please reach out to either DSAA or Emory. We're prepared for that and have scholarships available. Please don't let money be the reason you're not coming.
And spread the word amongst your friends. It's on a Saturday.
It's actually
Saturday
next
the 18th.
Saturday. It's a week from Saturday. So this was so wonderful, ladies. I really appreciate y'all.
Oh,
If there are no other
good.
questions, I'm going to let everybody go for the night. And we will see you at our next webinar and certainly hopefully see you next week at the Emory conference.
Good luck.
Take care. Thank you, ladies.
Thank
Thank
you.
you. Take care.
Bye-bye.